Good evening, everyone. I'm Judy Gassner, and I'm with the Torrance Memorial Foundation. And it is a privilege for me to introduce someone very special. Thank you for Zooming in, and I believe you're going to have a wonderful and formative hour. So it is with great pleasure that I introduce Dr. Mark Lurie, a beloved and respected physician at this medical center and in the community. A graduate of Rush Medical College in Chicago, Dr. Lurie came west to USC County Medical Hospital in Los Angeles for his internal medicine residency. He then completed his cardiology fellowship at UC Irvine and is a fellow of the American College of Cardiology. Dr. Lurie enjoyed a thriving cardiology practice for well over 41 years. And he thought he might retire, but not so fast. Today, he is currently the director of the Heart Failure Program, the president of the Torrance Memorial Health Foundation Board of Directors, the medical director of the Lundquist Lurie Cardiovascular Institute, and for 41 years, Dr. Lurie was a staff cardiologist at the USC Athletic Department. And he enjoys his life with his lovely wife, Barbara Deming Lurie. Hi, Barbara. Traveling, being with friends, family, and enjoying many happy hour dinners. Please join me in welcoming Dr. Mark Lurie.
Thanks for that great introduction, Judy. I appreciate it. And for all of you people visiting Miracle of Living, I've done these on many occasions, but you know, in the past they were in person. And this one, I sort of felt like Johnny Carson coming out with the announcement, because we have guys in the back, the media services, saying 5, 4, 3, 2, 1, you're on, and I feel like I have to entertain you, and I don't have a monologue. But it's a pleasure being here. First, I want to thank a lot of people. I know Mary Ford, who has the Miracle of Living, she's here. Judy, thank you for your participation in getting me through this. Sandy Vandenberg. Kara, our nurse here, who's going to be part of our demonstration at the end, or got that going. And of course, the Miracle of Living Committee. These people are committed to the hospital and getting a community education. I'm pleased to announce the great speakers we had. I noticed the smirks on their face when Judy was giving my introduction, but that's just part of being young, I guess, and my being old. But we have a great topic. I think and I've seen their slides, I think you're going to learn quite a bit about what a heart attack is and what isn't a heart attack, one of the most important things. And we will have a little surprise at the end to make sure you're getting some education that way beyond just heart attacks. So we have two speakers, and really proud that these are, you know, the one thing I have learned is these guys are incredibly smart and much smarter than I was, and I will make the confession, I would not get into med school now. So our first speaker is Wilson Kwan. He's a general cardiologist, trained non-invasive, so that's what we call it. He's accredited in echocardiograms, calcium scanning, and CT scanning, etc. He grew up, or he went to school in San Diego, med school at USC, did his training in internal medicine as well as cardiology fellowship at USC, and I guess a Trojan at heart, and he's here to speak about, he'll be here to speak about the MI. I should have, I already made a mistake. Our first speaker is Arash Aghel, and he came here through Colorado, but he's trained in Cleveland, at Cleveland Clinic, and then Cleveland Case Western in cardiology, internal medicine, cardiology. He was in Cleveland for several years. He says he never heard of me, but we'll still welcome him here. He's going to speak about what a heart attack is and show you and demonstrate what that is. Again, I apologize for going out of order, but Arash, you can start.
Good evening. So the way the talk is going to be today is We're going to start with a real-life case presentation of a heart attack and how it was managed. I'm going to show some images. I'm going to discuss some of the important elements about emergent cardiovascular care, including the systems in place to get where we are, and a little bit of a historic perspective. And then we're going to work our way back after we discuss this case of a heart attack and work our way back and discuss risk factors, symptoms, testing, etc. The objectives you can see here, fairly broad. What is a heart attack? When should you see a cardiologist? How can you prevent a heart attack? How are heart attacks treated? How can you recover after a heart attack? I will be covering a few of these, and my partner, Dr. Kwan, will go over the rest. So the case that I'll be presenting today is a 49-year-old with chest pain. The details of his chest pain are that he described it as crushing in nature. It was radiating to the left jaw over 90 minutes. Of note, the pain did wake him up from sleep. So his past medical history is that he has high cholesterol, not bad enough to warrant any medication. He does have a family history of heart attacks in his father and his brother at a young age. After he experiences chest pain for 90 minutes, his wife does call EMS, and we're going to circle back to this part. We can only do so much if patients don't come and see us. Educating you all about the symptoms of heart attack is where this most important step comes in, where patients actually seek care, and that's where sort of the steps for us to be able to take care of the patient start. So patient is brought to the hospital where he's diagnosed with a heart attack. The technical term for his kind of heart attack is a STEMI, which stands for ST elevation myocardial infarction, and this is a cardiac emergency. So he's taken promptly for an angiogram and ultimately gets stenting of his blocked artery. So these are his images. Just to orient you, on the left, the black that you see on this screen is the dye or the contrast that's injected into the patient's coronary artery. There's a moving structure on the top that's also dark. That's the catheter via which we've advanced this through the patient's right wrist, and we're using that to inject the contrast. So on the right, you see the right coronary artery that supplies the right side of the heart, and you can take my word for it, but that vessel looks fairly normal with a little bit of plaque buildup, but nothing that's contributing to this patient's symptoms. On the right, you can see two vessels that are branching like a V, and the bottom branch stops abruptly. That is where this vessel should continue down. So if this were not a heart attack, you would see continuation of that column of dark contrast, but you see it abruptly stopping because we're doing an X-ray of the contrast. So that is where the heart attack is, and that's why the patient is having chest pain. On a side note, this patient does have plaque in the other vessel as well, which we address, but the main heart attack vessel is that abrupt cutoff of contrast. So the way it works is we advance wires through the blocked artery, and you can see some small dark filaments sort of moving in this screen. And on the left, you can see a dark shadow inflating. That's the balloon inside of the artery. On the right side, you see additional equipment advancing. We use different modalities like intravascular ultrasound to characterize the vessel. And then on the left, you can see the repeat angiogram showing where there was a previous cutoff. There's now blood flow, but you can appreciate where the narrowing or the blockage started. It's almost as if somebody took a bite out of that vessel. So that's the area that caused the heart attack. So we now have restored blood flow to that area, and then we continue to treat that area with a stent. You can see on the right, the vessel looks fairly normal with brisk blood flow. And then in this particular patient, because there was another area contributing to his symptoms and needed to be addressed, we went ahead and fixed the arteries supplying the front of the heart. On the left and the right, you can see that structure in place on the left screen. That's the stent that's being positioned. And on the right, you can see that sort of tubular structure inflated. That's the balloon inside of the stent, which deploys that metallic structure in place and acts as a scaffold. And then you can see on the left that area that was restricted is now open. In the middle screen, you see a different view of that same image, again showing brisk flow. And on the far right image, you see a different kind of angiogram where we're injecting high volume of contrast inside of the chamber that is showing very vigorous and good contraction of the vessel, again showing that hopefully this patient has not sustained any injury to his heart muscle. So this patient's hospital course was that his pain that brought him into the hospital subsided completely after the procedure. Later that day, he gets a separate test, which is an ultrasound of the heart called an echocardiogram that shows that his heart muscle, thankfully, has not taken a hit, is not damaged. The patient is started on appropriate medication, is educated in the hospital over 24 hours, and the next day in the afternoon, he's sent home. So this is a great case with obviously an excellent outcome. And then I'm going to go over sort of what goes into this happening. It doesn't matter that you're in a good hospital or have a good physician, but it really starts with the steps leading up to the patient coming to the hospital. So how did we get here? There's a mantra called time is muscle. So the sooner you address a blockage, the sooner you can prevent damage to the muscle. Historically, if you go back before the 80s, the treatment of ST elevation myocardial infarction was pain control, managing arrhythmias, reduction of cardiac work. It was basically a dark ICU where patients rested without visitors and hope they get through it. The outcomes were nowhere near what we have now. Studies suggested that, well, if there was a way for you to restore blood flow, you could salvage the heart if you could get reperfusion. Started with animal studies and then translated into human studies. The first modality was a medication. Some people may know it as a clot buster. It was very effective. It's still used widely and showed excellent outcomes. Afterward, as these became more prevalent and coronary angioplasty, the technology allowed us to do an actual mechanical procedure to restore blood flow, and that's where PCI, or primary PCI, which is what we did in the setting of a heart attack, became basically mainstream. So the metric that we shoot for is 90 minutes or less, and there are a lot of studies that were done to get to this point, but if you look at this graph, you can see a linear relationship between time and outcome. So 105 minutes versus 90 minutes on the left, the lowest bar, has much better outcome than 120 minutes, 135 minutes, and 150 minutes. And on the right, you can see the relative risk of in-hospital death. It goes up by 20%, which is not much difference between a 105 and 120, but that's a 20% increase in that patient not making it out of the hospital. So this is a busy slide, but I want to spend some time regarding sort of the steps that go through how this patient comes in with a heart attack and then goes home the next day fairly, doing very well. So onset of symptoms, so identification of symptoms, which Dr. Kwan will speak about. And if you know what symptoms to look out for, you'll be able to call sooner and get help sooner. If you stay at home for 2 days, even if we get you into the procedure room or cath lab within 90 minutes, it's not the same. That really is identification of symptoms promptly and acute management. And then we have the system in place for dispatch, EMS, promptly taking these patients' calls, dispatching, stabilizing these patients, communicating with the ER. In a lot of places where primary PCI is not available, they can even initiate therapy. They could give patients clotbuster or thrombolytic therapy. And then there's the triage plan. Not every hospital has a primary PCI capable cath lab, so the network of EMS in hospitals, they have to be able to triage these patients based on an EMS diagnosis in the field of where this patient should be sent. And all of these steps have metrics. They have timing that hospitals are ranked, gauged, and sort of a metric that we follow for quality. And you have to meet these criteria to be able to offer this service. So how did we do? So wife calls EMS. EMS is dispatched, and the patient arrives to the ED for this particular patient at 4:13 in the morning. These are actual numbers. The electrocardiogram, which is the way we diagnose a heart attack, happens at 4:14. So if you come to the ER with a STEMI, everybody drops what they're doing. This is an emergency. The patient is diagnosed with a STEMI, which is an emergency. Patient is given nitroglycerin, aspirin, and heparin. The interventional cardiologist, which was me, and the cath lab team. So this is where, again, the system comes into play. I can't do this procedure by myself, nor should I. There's a single phone number that's called out for the team and person that's on call. We're all notified immediately, and we all arrive within 20 minutes. That team is paged at 4:15. Patient is brought up to the cath lab at 4:37, at which point we are already here. Procedure starts at 4:44. We get into the radial artery in the wrist at 4:45. The angiogram, which are the pictures, is done at 4:46. We advance the wire across the vessel, and we inflate a balloon, deflate the balloon, restore blood flow at 4:55. So door to balloon time of 42 minutes. So this is why the patient can go home the next day. The patient identified the symptoms. His wife called EMS. The EMS quickly dispatched. Our system functioned perfectly, and the patient did well. So a couple of schematics on what this looks like. So you have to get to the heart somehow. We usually go through the wrist, but there are other ways that we get there. I'll show that in the next slide. But essentially, there's a narrowing or restriction on the top left. We advance a wire through this vessel. That wire acts as a rail. A balloon, and sometimes a stent in this scenario, is advanced, which is mounted on a balloon. The balloon pushes away the plaque. The stent expands, and it basically functions as a scaffold and pushes away the plaque. The balloon is deflated, removed, the wire is removed, and then the vessel has restoration of blood flow. These are very small devices. They range from 2 millimeter to 6 millimeter in diameter, length of 12 millimeter to 48 millimeter. You can see a large view on the top, and on the bottom, a reference just to see how small these structures are. And again, the way we get to the vessel, on the left you can see a catheter, which is a small plastic tube. Now in most hospitals, and especially in Torrance Memorial, 95+% of these cases are done through the wrist. It's much safer, much easier for the patient. We advance a small catheter, and then we do everything through that small 3 to 4 millimeter catheter. And at the end of the procedure, on the right, you can see there's a wristband that goes on the area that we entered. Some of these devices, like this one, has a small air capsule where we inflate the air, compresses the artery. That wristband controls the bleeding. Patient basically goes back to their room with a wristband on. They can sit up, they can move, and usually they're completely awake. So do all patients do this well? Obviously not. The overall risk of a patient dying from a STEMI, which this patient had in the United States, between 2.5 to 10%. Obviously, there are patients that don't present promptly. There are patients that are older. They have different comorbidities. So this is why we're giving this talk. You know, this is a serious condition with a high risk of death. And one of the important things is that only 36% of hospitals in the United States are equipped to do this procedure. So if you're in a rural area, you are much more likely to get the clot buster, which is still a perfectly a good treatment, but the sequence of events and potential risks are different. And then what happens to these patients long term? Before the 1980s, after 5 years, there was about 30% of these patients that would die. Now, studies suggest in patients that make it out of the hospital, their risk of dying over the next 3 to 5 years is 3 to 4% only. Briefly, I'm going to talk about what happens after the procedure, and then we're going to backtrack and go over diagnosis, prevention, and some testing. But usually patients go home after 2 to 5 days. They go home with a follow-up plan, their medication that they're going to be started on. Lifestyle changes is key, obviously. And then we have a program which is covered by insurance. Most hospitals, or all hospitals that actually have a primary PCI program, have this. It's called cardiac rehab. There's exercise. There's programs on risk reduction. If a patient's a smoker, the smoking cessation, blood pressure management, control of their cholesterol and diabetes. And then a big thing is dealing with stress, anxiety, and depression, which is prevalent in these patients. That's all I have, and then I'll give it over to Dr. Kwan to go over the rest. Thanks for your attention.
Thanks, Arash. That was outstanding and I think highly educational. I do want to remind those of you who have zoomed in, there will be questions and answers at the end, and you can start submitting your questions anytime through the chat, and I'll see them here, and we'll send the questions to the docs after their speeches. Next, I already introduced Dr. Kwan. Again, he came through the USC program through medicine and cardiology. He's here as a non-invasive cardiologist, highly educated in imaging and treatment of things like MI. Don't forget, these people have to be followed for a lifetime. So we'll discuss the further aspects of myocardial infarction. Wilson.
Thank you, Dr. Lurie, for that very kind introduction, and thank you, Dr. Aghel, for that very stimulating talk on a very important topic in life-saving techniques. My job as a non-invasive cardiologist is to prevent all of you from requiring the services of my good friend and colleague, Dr. Aghel. A lot of this has been said, so I'll just highlight some of the key points, but again, cardiovascular disease and heart attacks in particular are a life-threatening illness and is typically the #1 cause of death in the United States. One out of every 3 deaths in the United States is caused by heart disease, with heart attacks probably being the most common culprit. Each year, almost 800,000 people will have their first heart attack. And every 39 seconds, someone dies of a heart attack. So, what exactly is a heart attack? So you've seen that very graphically displayed by Dr. Aghel. You can see, here is just an illustration, but what Dr. Aghel showed us earlier was, real images from a case that he was doing. But what you see here is a depiction of a heart, and the heart has what is known as coronary arteries. The heart is a muscle, as described, and has arteries that supply blood and oxygen and nutrients to that muscle, which is why it's so critical that those arteries stay open. A heart attack is also known as a myocardial infarction, okay, a term you may have heard before. And it happens when the flow of blood suddenly becomes blocked. And that's the key, it's sudden. It's not something that is gradual. That's a different entity, which we will touch upon later. If the blood flow is not restored quickly, then the heart muscle begins to die. And here we have an illustration of what is actually happening inside the arteries of the heart. And from top to bottom, you see a progression of what is known as coronary artery disease or coronary atherosclerosis. And these are the plaques that form as a result of cholesterol deposition and an inflammatory process which involves many different cells and signaling pathways, and is part of your body's natural healing process but can also work against you. Over time, particularly if you are predisposed with conditions such as diabetes, high blood pressure, or high cholesterol, you can get deposition of this plaque inside your coronary arteries, and eventually this plaque can actually rupture. And it's the rupture of that plaque that then causes oftentimes a combination of blood and platelets to form a clot on top, and that is what causes the heart attack itself. And that happens very suddenly. But the process that leads up to this is actually very gradual. One important distinction I also wanted to make is that between what is a heart attack and what is cardiac arrest. The two are actually very separate entities. A heart attack, as described, is a circulation problem when you have a sudden blockage of the vessel, whereas a cardiac arrest is an electrical problem. Dr. Lurie will talk more about this later, and I'm sure you've all heard about what happened in the Buffalo Bills game. And what happened was not a heart attack, it was a cardiac arrest. And in particular, a very rare entity known as commotio cordis. What happens is your heart actually runs on electricity, and it goes through a cycle of what's known as depolarization and repolarization. Each cell inside your heart runs on electricity and is part of what is known as the cardiac cycle. What happened during the game was the player sustained a traumatic injury to his chest at just the right moment, highlighted in pink there, during the cardiac cycle, where the heart is just, predisposed to being triggered and going into a disorganized electrical rhythm. And when it does that, it can beat too quickly and out of sync. And that results in low blood pressure and sudden collapse and death if not treated promptly. Going back to heart attacks, what are some of the common signs and symptoms? So the patient that showed up in the emergency room with the STEMI that Dr. Aghel treated so effectively had some of these signs and symptoms, and these are things that we should all be aware of. First is, of course, pain or discomfort in the chest. Second, lightheadedness, nausea, or vomiting. Jaw, neck, or back pain are also common, as is discomfort or pain in the arm or shoulder, classically the left side, because that is where the heart is located. Shortness of breath is also a frequent presenting symptom. Did I just have a heart attack? Okay, so we are often, presented with a case of patients who show up in the emergency room with chest pain. And, we should obviously not take it lightly. But it is also worth noting that nearly 90% of the patients who show up in the emergency department with chest pain are not actually having a heart attack. So, what are some of the things that may point us towards thinking that, you or I may be having a heart attack? Obviously, there would be all those symptoms which I described before, but also things including your risk factors and your age. Some symptoms which are less likely to be a heart attack, but still may present as chest pain, include sharp stabbing, poking, or pinching chest pain, pain that is worse with touch, pain that is worse with taking a deep breath, pain that only lasts a few seconds, and symptoms of pain or shortness of breath that actually improve with exercise or activity. These all suggest that these are not cardiac in origin. Some of the causes of this pain or discomfort include muscle, tendon, or joint pain, inflammation, gastrointestinal causes such as bloating, cramping, indigestion, and acid reflux, and nerve pain. Now, I still, implore all of you to take chest pain seriously, but keep in mind that if these are the primary symptoms, any of what you see listed here, then it is most likely not to be a heart attack. You should also be aware that there is a wide range of cardiovascular diseases besides heart attacks. And this includes narrowing of the arteries, and that's what I sort of alluded to earlier, where you can have narrowing of the arteries. They can be, 10%, 20%, 70%, even sometimes 90% narrowed without actually completely blocking off the flow of blood. And oftentimes, people can be blissfully unaware of the fact that their arteries are actually extremely narrowed. We'll talk about how to diagnose that in a bit. Heart rhythm problems are also very common and can be serious, as discussed. Tight or leaky valves, heart failure, congenital heart disease, which means typically someone who is born with a disease or a predisposition to a heart disease, and peripheral vascular disease, which is disease of the arteries and veins outside of the heart. When should you see a cardiologist? If you have recurrent worsening chest pain or shortness of breath, particularly if it is associated with exertion, this is a warning sign that you may be at risk of having a heart attack or may have narrowing in the arteries of your heart. If you have a strong family history of early cardiac disease or death, as Dr. Aghel mentioned in his case, the patient was actually a relatively young man, only 49 years of age, but he did have a family history of cardiac disease. And that is one of the risk factors that we often look for. If you have palpitations, which is a sensation of fluttering in your chest, or an irregular heartbeat lasting minutes or hours, particularly if you have passed out or feel like passing out, that could be a sign of a significant arrhythmia or irregular heartbeat. And of course, at the recommendation of your physician, your primary doctor, or other specialists. What to expect at a cardiology office? So this is very much a specialty that relies on various tests. And so that's one thing you can certainly expect. Blood tests, EKGs or electrocardiograms, extended cardiac monitors, which are devices that can be worn for a prolonged period of time and are displayed in the image on the bottom right, things that can monitor your heart rhythm, stress tests, echocardiograms, and ultrasound are other modalities that we frequently use to diagnose these conditions, CT coronary calcium score or CT angiograms, and of course, referral for coronary catheterization by our interventional colleagues. So what is a stress test? A stress test is just that. It's a test designed to simulate stress on your heart to try to elicit the symptoms or features that may be predictive of having a heart attack. Now, I know what you're all thinking. The man on the right probably is not at risk of having a heart attack. The image on the man on the left. The image on the right are obtained from what's known as a nuclear medicine stress test, which is just one of many different ways, again, we can assess the blood flow going to the muscles of the heart. Echocardiogram is essentially the same technology that we use to look at fetuses in the womb and is an ultrasound device that allows us to get very descriptive pictures and loads of information about what is going on inside the heart. We can examine everything from the strength of the muscle to the function of the valves and the pressure inside the heart without ever having to open up anything at all. And so, believe it or not, every day in our daily lives, we see calcium buildup, which is very much akin to what is happening inside our bodies as we speak. And so you see here a bunch of calcium on a shower head, on a pipe, and that's exactly the same process that occurs with coronary artery disease. Over time, there is buildup of calcium as a result of the inflammatory process inside and around the vessels of the heart. This calcium can be used and detected to help predict your risk of having a heart attack through what is known as a CT coronary calcium score, which is a service that is offered here at Torrance Memorial. Studies have shown that the calcium score is one of the best predictors of actually knowing whether or not you are likely to have a heart attack in the future, even if you do not have any symptoms at this time. The image on the left depicts the calcium in white overlying a coronary artery in the heart. The CT scanner in the image on the right depicts, what undergoing the study is actually like, and it generally is only about 1 minute or less, and is a very minimal dose of radiation. Now, our techniques have become even more advanced, and we can take this one step further through what is known as CT coronary angiogram, where we can add contrast and actually visualize, as you can see with these wonderful 3D renderings, the structure as well as the patency of the arteries of the heart. As mentioned, there is radiation involved in these studies, and for a CT coronary calcium score, it's as low as 0.5 millisieverts in our modern scanners. And just keep in mind that you have an exposure of several times that just from background radiation from the atmosphere and from the earth each year, so it's really quite minimal. How can we prevent cardiovascular disease? So lifestyle, diet, testing, and treatment are the pillars of prevention. An ounce of prevention is worth a pound of cure. So some of the risk factors that go into the development of coronary artery disease include high blood pressure, high cholesterol, diabetes, smoking, an unhealthy diet, physical inactivity, and obesity. Really quickly, on diet, one thing that we often recommend is what's known as a Mediterranean diet, and the key features of this diet are lots of whole grains and vegetables, as well as lots of fish and nuts. Particularly oily fish rich in omega-3 and omega-6 fatty acids have been shown to improve cardiovascular outcomes, as has olive oil and avocado oil. Regarding medical treatment, a moderate dose of cholesterol-lowering medication, which is always prescribed following a heart attack and ideally before one ever happens, has been shown to reduce the risk of cardiovascular events by 40% or more. A multimodal approach involving diet, exercise, and medication can effectively lower the risk of development or recurrence of cardiovascular disease. This is particularly important for those who already have a history of coronary artery disease. Please consult your doctor or a well-known resource such as the American Heart Association website for further information. With that, thank you, and I'll hand the mic over to Dr. Lurie.
Thanks, Wilson. I'll avoid hyperbole, but these talks, I hope you can appreciate just how good they are. And one thing over the years that I found, we've had many programs with cardiology speakers, and we all tend to extend our talks, go over and everything. These guys had such a compact presentation, so much information, and yet did it so effectively in a time that they were limited to. So again, thank you for doing such a great job. The next is the elephant in the room, and no, Barbara, it's not me. I think the thing that everybody is thinking about, Wilson addressed it, is what we had a dot on the announcement, You've heard of Damar, Hamlin. He was the football player who you saw had the arrest. But do you know who Denny Kellington is? And I think that's what the principle is. Denny Kellington was the head trainer for the Buffalo Bills. And you're going to have a demonstration here of how important that is. It's so important that when you can recognize an arrest, and you have to take, I mean, it's not a heart attack. Remember, it could have been a heart attack, but whatever it is, you're at the end of life at that time. It's called sudden cardiac death, sudden cardiac arrest. You have to address it, recognize it, and like Kellington did, you have to get CPR immediately, because for every minute the arrest is not alleviated, 10% fatality goes up. And then you have to have an AED. Torrance, many, many years ago, when the AEDs came out, we were able to distribute them to many places that we felt needed them. And now it's just all over. And the important thing is, the example of an athletic team is that you have a team. I know that at most of these big universities, and Kellington did it, it's not the doctors who are roaming around or who walk around, whether it be cardiologists, orthopedic surgeons. The trainer sets up a team. I know at USC, every year they have the practice. They have an expert come in to show how to remind them how to use the AED, and they're ready. And USC did have an event a few months ago. It was in the paper today, and that patient, remarkably, unlike Mr. Hamlin, that patient was up and awake within minutes. That's what you hope for. So what we're going to do now is just show you that the facility, how easy it is not to be frightened. The CPR can be started, and this isn't an instruction course. This is to show you how easy it is to get the AED, the automatic external defibrillator, and work it. The nice thing is there's some man in that little defibrillator that's going to tell you everything to do. And we'll now show you how this works. Our fantastic media service group is here, and they're going to start the film. Already seen the lectures about what a heart attack is, what other issues are that resemble a heart attack but are different cardiac abnormalities. Now we're going to talk about what a sudden cardiac arrest is and how to treat it. Remember, there was a bullet point or a question on your invitation saying, you remember Damar Hamlin of the Buffalo Bills, but do you know who Denny Kellington is? Denny Kellington is the trainer for the Buffalo Bills. He's the one who initiated the treatment for the football player. He recognized the abnormality, the problem that he was not having a pulse. He started cardiac compressions and called for an automated external defibrillator, the defibrillator like this, to shock the patient's rhythm and bring him back to life. This is what saves the lives of the people who have sudden cardiac arrest. Most people with outside the hospital cardiac arrest have the problem of only 10 to 15% surviving to go out with a normal function. That's why it's so important for everybody to have a team effort such as Danny did, or learn how to do this, and it's quite simple and safe, so that we can start having more life-saving treatment as an outside effect. So here's our team. We have Eric, our paramedic, and Marie, our nurse. Most of us won't be that lucky to have this kind of team outside, but all of you can do what they're gonna do. We're not having a lesson, we're just gonna show you how simple it can be to save a life.
Sir, are you okay? I'm checking for a pulse. There's no pulse. I'm gonna start compressions. You, get the AED. You, please call 911.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light. Apply pads, plug in connector. Analyzing heart rhythm. Do not touch the patient.
Okay, don't touch the patient.
Shock advised. Charging.
Stay clear.
Stay clear of patient.
Okay, stay clear.
Deliver shock now. Press the orange button now.
Clear?
Shock delivered.
All right, you can see just how easy that was, and that was a life save. This gentleman is now going to be functioning well and get out of the hospital. This is something we all have to remember. When we're outside, we're not always going to have a paramedic to defibrillate. We're not going to always have a nurse to direct us. But these things can be done quite simply. Remember, you have to identify that the patient has an arrest. You have to start compressions immediately. Do what you can wherever you are to have the AED or automated external defibrillator. And I think we can all benefit from this. Thank you. Well, for that, I'd like to thank Kara, who's out here. She was the one who helped formulate this whole program. Our media services gentleman in the back filmed it for us, and we just filled in. The nice thing about that team, Marie, that's a very pleasant family. That was her son, who was about 3 feet taller than she is. But again, you're not going to have a nurse. You might be alone. You know, the airport has them. Hopefully you're in a crowd where you could yell, get the AED and bring it out. The main thing to realize, it really is easy. I'm not trying to be condescending. They speak perfect English. It's loud, and you just follow it step by step. And I think it then shows you can, again, hopefully you can avoid seeing Arash, and hopefully Dr. Kwan's going to keep you from ever having to need that. So I hope that was educational to you. Okay, so we're going to start with the questions. They've already been coming through, and I just realized I wasn't talking in the microphone, so we'll go back to beginning. Okay, the first question. Before a heart attack, are there any signs? Does angina always warn you of a heart attack? Wilson, you.
So, we good? Your life? Okay. Yeah. Does angina warn you of a heart attack? Yeah, that's an excellent question. What is angina? First of all, angina is referring to a particular type of chest pain, which has a lot of the typical features that we talked about earlier, pressure-like, associated with exertion or activity, and it is one of the signs and symptoms that can give you a clue that your arteries are becoming more and more stenosed, which is a term that we use to describe the tightening of the arteries and the development of plaque. And that doesn't always lead to a heart attack, but it is something that many people experience, and that will lead us to do some of the testing that I had talked about, such as stress testing, as well as CT coronary angiograms, and ultimately refer them for a coronary angiogram, which is what my partner, Dr. Aghel, does. And the whole idea is to catch this before it becomes a heart attack.
Very good, thank you. Next, Arash, in case if you are in too late. Actually, that starts one of the Beatles songs. All right, I get the message. Okay, if you are in too late, what should the doctor do next? Arash?
If you are in too late, what should the doctor do next?
Or what will the doctor do? I think this isn't like a stroke where there's a limit, but what would if they come in too late, is it too late? Is there a thing that's too late, or?
It's never too late.
Okay.
So at any point, you identify or realize maybe the symptoms that you were having could be a heart attack, you should come in. There's different sort of degrees of heart attacks. Some of those symptoms that may sound like you have already sustained a heart attack a day or more before coming in may have been warning signs. Taking aspirin or other medications could briefly restore blood flow back into the artery. So just because your symptoms started 2 or 3 days ago doesn't necessarily mean that you've been sitting with a blocked artery for 3 days. What we showed and depicted in my case is a certain kind of heart attack where the vessel is completely blocked. You may come to the hospital with a different kind of heart attack which is not an emergency. That's where you may be seen by a cardiologist, and you may have this angiogram the next day or 2 days later. So that's not necessarily emergency. So long answer short is whenever you have the symptoms, you come in and there are definitely things that we can do.
Thanks, Arash. And, yep, don't wait. Wilson, this is a question I think you can answer. How do heart attack symptoms show up in women? I know.
That's a very good question, and thank you to whoever asked that. So I know that in recent years there has been a lot of focus on women's health, and heart attacks and women's heart health have certainly come to the forefront of our collective consciousness. So it is important to note that in women, there are often slightly different or sometimes quite different signs or symptoms of a heart attack. And I would say that certainly we would still look for the same features that we discussed earlier, which would be pressure like chest pain, jaw pain, arm pain. But in addition, things such as abdominal discomfort, a feeling of nausea, vomiting, or just general discomfort in your abdomen or lower, and also fatigue are more commonly seen among female patients presenting with heart attacks than men.
Thanks. Always a difficult question, but important. Next, Arash, what does the ST stand for in STEMI, and what does elevation refer to in STEMI?
So one of the first tests that we do when a patient comes in with chest pain is an electrocardiogram or an EKG. So the ST stands for a certain part of that electrocardiogram that is affected when there is lack of blood flow. So the blood flow affects the electrical current, which is what we see on the electrocardiogram. And the elevation is essentially rise in that ST segment in reference to where it should be. So you have all seen those tracings of a blip where it goes up, down, and then you have a straight line. That straight line in the ST segment is elevated. So that's one of the ways that we identify whether a heart attack is an emergency or not. So that's the ST segment.
I can't ask if that answered the question. It certainly did to me, and thank you. I know that's a complex thing. You guys got that? Yes. We have the surrogates here. All right. When you have the radial artery procedure, Arash, are you awake?
So yes, but you are sedated. So you get medication to make you sleepy and drowsy, and that can vary from patient to patient. Some patients are asleep by the time we get into the artery, but most patients are conscious but sedated. So if we ask them to move or take a breath or ask them how they're feeling, they would be able to respond, and that's what we want to do. But it's not a painful procedure. It's as painful as getting an IV placed. So we use a very small needle to numb the area with lidocaine, and after that we place a very small catheter. So you're conscious, you're comfortable, but you're awake. You're not in pain.
Thanks. Wilson, when you call 911 and the paramedics arrive, can they diagnose an MI in the field? If they do, what happens at the hospital?
So typically, if a MI or myocardial infarction is diagnosed in the field, the emergency medical services will transmit that EKG to the hospital triage, to the emergency room. especially if it's what's known as a STEMI receiving center, as Dr. Aghel talked about earlier, meaning a hospital with the capabilities of dealing with this type of emergency. And from there, all of the machinery, the complex machinery and logistics are activated, and the interventional cardiologist is called, and essentially everyone is called into the hospital to try to get the patient in as quickly as possible, and to get that door to balloon time, which we know is so critical, down.
Great, great. I'm going to quickly answer this because these guys have a lot of important questions to answer, but is TMMC a heart center? Well, heart center is a term that anybody can use. I could put a poster up in front of my house and it can be a heart center. If you want to, is it a heart center? Torrance is. There, as you know, it's a STEMI receiving center. It's part of the base station. It is a stroke center, but it's a heart center in that it can give you all the services outside, say, of a transplant or some complexities that you need to take care of your heart. And this heart center, so to speak, or the institute, was developed when the Lundquist family said if they had a heart attack, they didn't want to have to drive up the 405. So yes, the answer is it is a heart center, but in reality, you have all the things, all the complexities, all the treatment needed for heart problems. Okay, next question. How long for plaque to build up, and does age affect this? Wilson?
Good question. So the development of plaque is really a lifelong process, and the speed at which it develops is highly dependent on many variables, probably number one being your own genetic predisposition. Studies have looked at the arteries of young people, even teenagers, and seen early plaque beginning to develop. Some people, as I have seen with my own eyes from these CT coronary calcium scores and on angiograms done by interventionalists like Dr. Aghel, may be well into their older age and still have very little, if any, significant plaque or coronary artery disease. So short answer is it depends.
That is short. Actually, this is a question that Arash answered for me just before. If a patient, before the talk, if a patient, male or female, is over age 65 and wants a coronary calcium score test performed, what is the proper mechanism of getting this test performed with insurance coverage? You can be the bad guy.
It's not universally paid for by insurance, unfortunately. So there are some exceptions, but most of the time this is a self-pay test.
Wilson, does red yeast rice, I didn't know that's still around, does red yeast rice help with high cholesterol?
Red yeast rice can help with high cholesterol, although its effects can be sometimes hard to predict. And for that reason, we do not prescribe it as a treatment for treating high cholesterol, but it does have known effects which can sometimes lead to measurable reductions in certain types of cholesterol.
And I guess one of the things to remember is there are tons of studies going on all the time. And what you want to know is if you lower your cholesterol with whatever mechanism, what's going to be the outcome as far as heart attacks, death, and all that? Because there might be some bad ways to lower it. So you want to talk with your doctor and get the evidence, and that is exactly what Wilson was talking about in his talk. With a high number, again, I'll give you this, Wilson. With a high number of artery calcium score, about 2,200, what would be your recommendations to treat this and prevent a heart attack?
So with a calcium score of 2,200, you'd certainly be at elevated risk of having a significant cardiovascular event within the next 5 or 10 years. And typically, we would put you through some type of stress testing, whether that be exercise, nuclear, or the exercise or nuclear stress testing. And if those results are inconclusive, we will often refer the patient for what is known as a coronary angiogram. And we would not be able to use a test like a CT coronary angiogram, which is one of the non-invasive means, because that high degree of calcium actually obstructs our view in imaging. Because what happens is it shows up as white on the scan, while the calcium, while the actual contrast agent that we use is also white. So it's basically white on white. But in the techniques that our interventional colleagues practice, the contrast shows up as black. So we're actually able to see the lumen, the diameter of the vessels, and determine whether or not there's any significant blockage or stenosis that is developing and treated.
Great. Arash, I'm going to give this to you because Arash also specializes in treating and evaluating vascular disease or peripheral vascular disease. In my simplistic way, if you have vascular disease any place, your risks are great no matter what. That's atherosclerosis. So for this question, Arash, is it still a good idea to take aspirin as a preventative for heart attacks or anything? I think I heard that, or this person heard that the theory has changed.
I would say that the general consensus at this time is no. So no, you should not take aspirin for prevention of heart disease unless you have certain risk factors and your physician recommends it. So in the past, it was just an over-the-counter, yeah, sure, take it. It'll prevent heart disease. It doesn't come without a risk. So without speaking to your physician, you probably shouldn't just take it for prevention.
Great. Wilson, if you have plaque, how can it be reduced if that is possible?
So very good question. Reduction of plaque burden has been sort of the holy grail in preventative cardiology for some time now. And there have been many studies to address this exact question. Unfortunately, it is something that remains relatively elusive, although some newer medications, one called Vascepa, has been shown to reduce the amount of calcium that we can see in these arteries. Now, even if you're not able to really get, say, the size or the burden of that plaque down, we do know that taking these medications, such as statins, which we routinely use to treat high cholesterol, can help stabilize these plaques that already exist and prevent them from rupturing and leading to that inflammatory cascade and that sudden blockage of the artery, which is what ultimately causes the heart attack. So even if we're not able to reduce it, we are able to stabilize and prevent disease.
Okay, actually, Torrance has a physician who specializes in cardio-oncology for certain problems. So I'm going to throw this question. One of you guys can raise your hand if you feel comfortable answering this. Does radiation and or chemo treatment cause a greater risk of future heart problems?
So I'll take the radiation. So patients that are exposed to chest radiation are at risk for accelerated heart disease. Not the radiation that somebody would get now. This is radiation from probably 30, 40 years ago, where they didn't take necessary precautions. One example is childhood lymphoma is a big one. The radiation does cause certain kind of plaque buildup in your arteries. Right now, you're not at any risk for developing accelerated heart disease if you were to get radiation, say for breast cancer or any other condition at this time. But if you had it as a child, you could be at high risk.
Regarding the effect of chemotherapy on the development of heart disease, chemotherapy has been frequently associated with a type of disease known as cardiomyopathy, which is generally a dysfunction of the squeezing or relaxing function of the heart. And This is a well-studied and known phenomenon. One of our partners, Dr. Brendan Bauer, actually specializes in this exact field. But it is one of the reasons why, you need to work closely, or we need to work closely with our oncology colleagues to help monitor the heart health of their patients as they undergo chemotherapy. And just a quick note, there are certain chemotherapies that are known to cause cardiomyopathy or heart problems much more frequently than others, and that's a whole nother talk unto itself.
So if you are undergoing that treatment, the oncologists here know to deal with the cardiologist, and especially Dr. Bauer, to make sure this is monitored, and echoes are done frequently with certain medicines. That was a great teamwork. You guys, that was really impressive. Is there a risk with the dye used in taking the coronary angiogram, Arash?
Yes, so this is the same dye that's used for a contrasted CT scan, the intravenous, not the oral, but it's the same idea. It's iodinated contrast, and we use that to reflect or deflect the X-ray that we give to be able to visualize. The contrast has evolved. It was very viscous and had a significant risk. Years and years ago, you can get allergic reactions. You can have cardiac arrest from an angiogram. The contrast that we use now has very similar features to blood, and it's not anything that would irritate the heart when we're doing injections almost ever. But it is cleared by the kidney. So if you have kidney problems, you could be at higher risk of getting worsening kidney function, but it's not an excessive risk. And the volume of contrast that we were to give for a regular angiogram could be as low as 30 to 40 cc's, which is a few tablespoons. Obviously, for an intervention, that could be much more. But with the amount of contrast that we give for the procedure, the risk of kidney function is pretty low unless you have underlying significant kidney disease.
I have, thanks, Arash. One more question. We are running out of time. Unfortunately for these guys, they have to work starting early in the morning. I'll be watching Mary Tyler Moore, but we want to give them some time. One question. I have been taking calcium pills, and Wilson, either one of you can do it, but Wilson, this might be in your area. I've been taking calcium pills for years due to a diagnosis of osteoporosis. How do I tell if I am damaging my heart? Or what do you think about calcium supplements?
That is, the jury's still out, but you're not going to damage your arteries. There's some data suggesting that there could be increased deposits on other structures like valves and so on. So if you need calcium supplements for an appropriate medical reason, osteoporosis is a big public health issue as you get older. So you are not compromising your heart health by supplementing your calcium vitamin D.
Great, and I see Wilson nodding. So that's going to complete our program. I want to say one other mistake I made. I want to thank our whole committee, and Julie Taylor is here, one of my Buckeye friends, and she's part of this group. I really want to thank all your help. Again, thank you guys. You did a fantastic job. Things have improved so much since my day, and I appreciate your work. You know you're going to be doing it again, and congratulations on making Torrance a heart center, and I'll put that sign up in front of my house. Thank you all. See you the next time.